So thank you. I'm glad to be here. And also, I want to really applaud the work of ESMO to take on this issue and to be so persistent and consistent in the work. And also part of the work of UICC, which has been extraordinary, and I'll refer to that. So I do think there are solutions, and I wanted to address a couple of the questions that were raised because I may not specifically address them in my talk. Dr. Kerr asked, do we do it vertically or do we do it at a country level? All of these, because there are international conventions, we have to do it at an international level in part, but that's not going to work. We need to do it country by country. So it has to be done at a country level. And so I think the kind of efforts that an international pain policy fellowship, which is run out of the University of Wisconsin, is a wonderful model where we teach advocates within the country to analyze their laws, to look at the regulatory barriers, and to address this. So I think country by country is the way. So I think the way ESMO could do that would be instructing their country societies, their member societies, of how at a national level they move this forward. I also think it would be great for UICC and ESMO to put enormous pressure on INCB, because all they do is talk and basically do not much more than that. So they are in charge of this, and they don't do very much activity, and they are not easily to be lobbied or directed. And I think all of us have worked hard to be with them, but I think they need some external pressure to ask some demands to be put on them to look at the country level and to look at how countries are accessing this. On the question of what do doctors do, I think, Florian, you asked that question. It's about dual loyalty. So I think the example you saw in Ukraine, that with Jim Cleary in that video, is a compelling example that we basically think is torture, and we've called it torture. What we see is a country that has only injectable morphine available. That particular man wasn't even receiving that, but other patients only get injectable morphines. And Human Rights Watch, in their compelling report on Ukraine, interviewed oncologist after oncologist who said, the government says I can only give 50 milligrams and I will give no more. And I'm very respectful of those oncologists because they're paid for by the government. So that's all they can do. So that becomes an ethical dilemma of the dual loyalty of the physician to the patient and then to the government. And so again, I think ESMO, within the Ukraine Society of Oncologists, can say this is a way that we need to be able to protest to this policy, because it's not a standard of care. It's not an international standard of care. You're not delivering what we call high cancer, appropriate cancer care. And to the issue of how we address the supplies in countries, it's an enormous difficulty, because we've recognized clearly in Central and Eastern Europe the lack of suppliers who will come into the country, register morphine, and try to sell it because they don't see that there's really clearly a market for that. So we're hoping, and we're glad to have ESMO join, and we're working with UICC on this at the present time, is to, with UICC, with the Pain and Policy Studies group, with our own group at the Open Societies Foundations, bringing together the suppliers of morphine with the WHO and asking them what information do they need. This is what the market is. This is what the potential is. This is a generic drug. How do we make it available? And seeing whether there's some way to help support that effort of how suppliers might see that there is an appropriate market to make these drugs cost-effective, to keep them cheap, and to make them widely available. So I'll stop on that, but those are sort of the efforts that we look at constantly when we look at the policy issue, because it is the policy issue that's going to drive all of this. And all of this started, and I want to remind and really give credit to Jan Sternsvard, who was then head of the cancer unit at the WHO in the early through the 1980s, who said, nothing would have a greater impact on than using the knowledge that we have now to improve the care of the patient with cancer pain. And so from the very beginnings, he was a major advocate. And as we talk about pain relief, I think none of us want to see it as solely an issue of pain relief. We want to make it very much embedded, much more into a much more comprehensive program. And so this is the classical three-step analgesic ladder. There are people that want to use a two-step analgesic ladder, even some that would like to use a one. I'm not particularly held to the 3 steps, but they've seemed to persist at the present time, although WHO is strongly considering, and has for children, taking codeine off the essential list for children. So morphine continues to stand as the essential drug. And these were the early monographs that sort of defined this issue. And this is the public health policy. And this is really what I want to focus on, because I think if we're going to try to address the availability of opioids, we can't do it in a vacuum. It has to be part of a more broader policy. It needs to be part of a national cancer control policy. It needs to be part of a national palliative care policy. And within that framework, then, the country can have drug availability. It can have the education of both the public and the profession, and can have clear implementation plans. And clearly these need to be very dependent upon the context in the country, and then we need to be able to measure outcomes. So one of the outcomes that we look at the progression of palliative care, an indicator that UICC has worked hard for the NCDs for palliative care, has been just the availability of morphine in the country, because it's pretty hard to do a broad palliative care program for 80% of patients with far advanced disease with cancer that have pain if you don't have morphine. So using morphine as an indicator is a very gross but potential indicator for the development of palliative and hospice care in countries. And when we look at this model, we can embellish it in much more greater detail, but I think that we don't want, in any of our discussions here, to suggest we just want oral morphine. We want much more than that. We want these clear policies. So we think at a country level, we need a national palliative care policy, and we have great models for those. And we can make those available, and they're posted on websites. We need clearly regulatory changes, and there's some, the Cancer and the Law group, are working on model legislation that countries could then adapt. And we need public and professional education. And I think one of the difficulties is that we don't have the large civil society voice of cancer patients asking for pain relief. They're asking for cure appropriately, but they're not necessarily fully educated about the importance of pain relief until they themselves experience cancer or their family member does. So we need to have a growing number of civil society participants in this discussion and debate, and they're currently lacking. So one of the works that we do at the Open Society Foundation's International Palliative Care Initiative, which is a funded effort to begin to advance palliative care globally, is we try to go into a country and identify a national champion. And then we do a needs assessment. And so we've done these in probably 15 to 20 countries, and predominantly in Central and Eastern Europe and now in Africa. And then we hold a national stakeholders meeting, and we bring the players together. We create various government task forces, and then we developed a palliative care, helped them develop a palliative care concept for the country. So in a way, what we're asking ESMO members is at a country level to work on these projects and to be advisors to other countries that might need your help. And within this, the elements are that the important aspects of all of this is that we use the international documents basically as symbolic language. It strongly supports it, the WHO supports it, et cetera. These international documents that I'll show you in a minute help to guide this policy development at a country level. And yet then these passionate, committed champions, and many of you are here today, are the individuals that are sort of pushing this forward within their countries. And it seems to me that these ESMO-designated centers for palliative care could be focal points for these wonderful champions to begin to be helping to move these standards forward at their government level and also at the level of the essential medicines. And we, as a funder, have been able to provide financial support for this kind of technical expertise to these countries, and have used consultants like Jim Cleary and others to work on these kinds of projects. And so this is a very complex slide. I don't expect you to even see it, but these are the sort of ways that we create this palliative care roadmap for implementing a WHO policy. And then these are sort of the examples of different countries where they're at different places in this. And I just want to show this to you because it is a little complex, but it's quite systematic, and it's based on clearly a public health approach to this issue. We need policy, and concurrent with policy, we need professionals. So let's look at this extraordinary language that's out there. The Council of Europe, in its recommendation 24, said in Europe, palliative care needs further development. It obviously identified the insufficient availability of opioids. It identified the legal barriers. It identified the need to make opioids available, and it said fear of abuse should not hinder this access. I think this is important because now the data that ESMO is presenting gives further fuel to say this is what we found from the Council of Europe. This is an old recommendation. It's now almost 7 or 8 years old, and we're still not doing very well. So this is, in a way, calling the Council of Europe to attention about this. This is the INCB, incredibly positive language. We just need them to act on this language. This has been quite positive. They say it in a positive way, but the minute the concern about drug abuse comes into play, there's not much that happens. In 2005, the United Nations resolution, again, very, very strong, as Eduardo said, symbolically important language. And then in May 2005, the World Health Assembly adopted a clear cancer prevention and control resolution, again, strong language to emphasize the importance of cancer control worldwide, provision of palliative care, need for improving of opioid availability. The Committee on Narcotic Drugs, in 2010, again, a very important agency that we need to work with, we need to begin to influence in a better way, is to promote this adequate availability. So we have lots of symbolic language, and I think the problem with this is everybody is for us, but no one does anything. So we need to now make them do something. And so the WHO has put out this, wonderful document on cancer control and how a country can plan a cancer control program and have a specific one that focuses specifically on palliative care, that says there are core programs, there's more advanced programs. This is how a country starts. This is how we embellish this. And so I don't want to argue for any pain, access to pain medications without it being in some type of a comprehensive health policy in the country. It needs to be in the cancer control program, a palliative care program, a strategy for the country, because this is how we embed it and we'll be able to sustain it for the future. So we have this sense of urgency from these UN organizations. We have the International Narcotics Control Board, the World Health Organization, the World Health Assembly, the UN Economic and Social Council, the Commission on Narcotic Drugs, all arguing for this. And you heard previously how Human Rights Watch has now taken on this cause and has done reports for Kenya, for India, for Ukraine, and is now doing reports on Mexico, Armenia, and Russia. So we will have really a host of studies from Human Rights Watch, who, with the WHO, has acknowledged that access to pain relief is a human rights issue. So let me, rather than take you through some of these slides that I have now, I want to move to some of the successes because we sort of have a limited time here. So I'm going to move to the successes because you've heard a lot about this. So I think one success, and this is something that Lucas has alluded to, but he's been very much one of the leaders in working on it, is an ATOME project supported by the EU, which is to have 10 country teams, 12 country teams, 10 partners, 5 years, one vision, and the vision is to improve access to opioids across Europe. So this, I think, is an extraordinary program. Here are the countries, the 12 target countries, and again, what they're doing is looking in depth at the regulatory environments in these countries and coming up with approaches and standards to how we look at this. So this is where law and health need to be very closely allied, because it's these regulatory barriers that we need to change. And this is something that oncologists are not trained to do, are not good at doing. And so this is where our colleagues in the law can be enormously helpful. In this project that Lucas and with the WHO is leading will give us, I think, an extraordinary framework for Europe to begin to work on this. So this is a policy agenda, this is an approach to use, and hopefully Lucas could answer more questions. I think the GAPRI that you heard about, this Global Access to Pain Relief Initiative, is another example of, again, the work of UICC, in support of UICC, to move this and call attention to it. But more than calling attention to it is the critical access of supporting and strengthening government leadership. So one of the focal activities of GAPRI is to embed in national governments in resource-limited countries like Kenya, like Nigeria, hopefully soon Ghana, is an individual with expertise to work in the government, to work on regulatory reform, and to be able to provide the technical assistance necessary to make these kinds of changes. And so GAPRI, as well as I previously alluded to, is also working with us on this supplier network and bringing together the suppliers. So having a fellowship program embedded in the country and having a broader effort to look at the supplier network is another approach to begin to address these policies, and I think has the potential for being quite successful. So there's the GAPRI supply project in Uganda, which has been pretty amazing. Here, they literally, GAPRI brokered a deal between the government and an NGO, which happens to be Hospice Africa, Uganda, to create a national morphine production program. So there we have an example where a Hospice Africa, Uganda, an NGO, has taken on being the focal point for availability of morphine in the country. If we look at Nigeria, this is a 3-year partnership with the Federal Ministry of Health, the consultants in the Department of Food and Drug Services. Now Nigeria has placed its first order for morphine in 4 years, and it's working both with the HIV and cancer communities to integrate pain relief. So this is another positive way to begin to do these activities. The WHO has recently come out with new guidelines for pain in children, and these guidelines, again, are the policy documents that at a country level we can demand that there's appropriate access to pain relief for children in these countries. And clearly, this is enormously important. These guidelines now have been created with a focus on education for physicians and nurses, important information for policymakers. And this particular blue document, again, you can download from the WHO website, is a way to begin to look at and show to the policymakers how they could begin to look at their regulatory environment and make access to pain relief for kids possible. And then this is one for pharmacists. So again, covering the gamut of individuals who need to be a part of this initiative. You've heard from Jim about the work of the PPSG, but these are the countries from which international pain policy fellows have come. And these, we think, are the champions. These are our new leaders at these country level. So now in 2012, there's a series of fellows from India, Bangladesh, Sri Lanka, Albania, Kyrgyzstan, and Ukraine. Again, individuals who are working together, spend a week at the University of Wisconsin learning about drug policy, and then are mentored over a year to 2 years in learning about how to make these changes possible, all at the policy level. So let me give you some examples. So Romania, a country where the Pain and Policy Studies Group had worked with very closely. This is a country that after a meeting we had in Budapest in the early 90s, emerged as a country that looked like they might be willing to change their regulatory environment. So they had, at the time, we looked at them, 35-year-old policies. They had no independent prescribing beyond 3 days. The opioid analgesics was limited by the patient's diagnosis. They had to have cancer. There was a limit of 60 milligrams of morphine a day. A 10-day prescription was possible, but very complex authorization. The new policies, 30-day limit, physicians with specific specialties or those who've received training, not limited by patient diagnosis, no limit of daily dose, and much less burdensome for physicians and patients' family. And Romania is a country that's developed a broad, expansive palliative care initiative, a great deal of leadership, and a wide range of champions at both a physician and nursing level. So I think this is beginning of a success story. Colombia is another success story. Here, the prescription amount went from 10 days to 30 days of medications in 2005. There's a major attempt to improve the distribution of morphine from warehouses in Bogota to rural areas. There's been a success in ensuring at least one pharmacy in each district stocks opioids 24 hours a day, and that came from an individual who was dying with cancer, whose mother wrote a piece to the newspaper basically saying to the president of Colombia, you know, my daughter is dying and it's not the cancer that's killing her, but the pain, because she could not access availability of pain medicines because the pharmacies were not available on a 24-hour basis. And it was that kind of advocacy that got the attention of, at a more presidential level, to begin to make these changes. And the Colombian Senate has passed a new palliative care law in 2009. So these are the ways we move forward. And this is the advocacy in Colombia. Pain is killing me because for several days I've been unable to find injectable morphine in any place. Please, Mr. Secretary of Health, do not make us suffer anymore. And this, again, was a wonderful advocacy effort. If we look to Guatemala, again, you saw the limits of availability of opioids in Latin and South America. Here, this is, again, working to improve the morphine supply from Guatemala City to rural areas. This is working on using much more sophisticated pain management appropriate drugs. And in 2009, the government agreed to accept assistance in how they might calculate their national estimates. Each country has to calculate a national estimate, submit it to the INCB, and then the INCB will approve it. And we don't have any reason to think the INCB will not approve these amounts that are calculated. The problem is that they have provided countries with ways to calculate these assessments, but they don't necessarily enforce them. And if countries don't send in calculations or requests, they don't identify the country as problematic or seek to try to understand what's happening. This is the first prescription ever written in Guatemala for immediate release oral morphine. This is the work of Eva Duarte, who's been an international pain policy fellow. And this was for a 72-year-old woman with advanced head and neck cancer. This is 2012. This is pretty extraordinary because in this same center in Guatemala, this person could have gotten a bone marrow transplant. So having these incredible ranges of access to certain types of sophisticated care and not simple analgesics is not what we should be doing, and it's not what we who work in oncology and wish to advance cancer pain should allow. So Nigeria, I've given you the example of embedding this individual in the country, and the government authorities have been very supportive of being able to work on this issue. Let's look at Serbia. Again, a pain policy fellow there has been working to encourage the government of Serbia to adopt a national palliative care strategy. So they have done that in 2009. Opioids are essential for pain relief and palliative care. Now this is in a government policy. And the need to examine national drug control policies and harmonize them with other EU policies. So this has been very helpful. We've argued that no country should be allowed to enter the EU as they're currently applying unless they have morphine available for cancer pain, unless they have a palliative care policy. And it's these kinds of advocacy efforts that can be very helpful. Armenia is now trying very hard after a national assessment to work with its National Institute of Health, and its pharmacy has agreed to import a certain amount of drug. The problem is we're finding difficulty finding a supplier for Armenia. And there's broad continuing education now for physicians and pharmacists on palliative care. You've seen this Human Rights Watch report on India, which is quite compelling. Go to the website, see the videos, they're extraordinary. And we're seeing the results of this kind of advocacy with the recent attention to Indian issues in the press, and more recently their Supreme Court hearings. This is the morphine manifesto that was supported by the wide range of different groups, arguing for the immediate availability of immediate release morphine as a first step. But again, this is something that you can download and use at your country level if you wish. So let me give you just a couple more examples of this kind of advocacy. This is the Ukraine Human Rights Watch report, which is quite extraordinary because if you hear the interviews with the oncologists, they're the most compelling points. Of course, my patients are in terrible pain, but the government says this is all I can do. And the physicians are placed in this extraordinary position of not being able to do it. And this is the video of Vlad, which we have called torture in healthcare. And with Human Rights Watch, we now have the UN Special Rapporteur on Torture, who is going to do a special report on lack of access of pain medications as a form of torture. This means that we can call governments up before the UN Rapporteur and his hearing committee and point this out. But this is a young man who got the best of cancer care, which was ineffective. He was sent home to die. He had great care at home by both his mother and friends, but he only got 50 milligrams of morphine, IM a day, and it only came when the nurse could come. and he suffered in terrible pain. And this story is quite compelling, and has been so compelling that it got the Minister of Health fired in the Ukraine when it became available on national television. So we think Ukraine is moving forward, but it's this kind of advocacy that's necessary. And now these are the wonderful campaigns that are now, if you are in Kiev, you can see these. Pain crippled me more than cancer. Seeing my patients suffering and not being able to help is killing me. And it's these kinds of billboards that are playing a major role in getting the public to understand this issue. And they're quite compelling. And this is part of a campaign, which is called the Campaign to Stop Torture in Healthcare, which is supported by our foundation. And lastly, I will stop with Uganda because it's a great success story. So in 1998, the Ugandan government developed a national palliative care and pain relief policy. It developed new drug regulations. It updated their essential drug list. It developed country estimates. It then created a strategic health plan, added liquid morphine to the essential list, adopted a new set of guidelines, authorized prescription by nurses. So these are really forward-moving efforts that we're seeing from a series of limited resource countries. Much of this work of Uganda has been the work of Anne Merriman and Hospice Africa Uganda there, who deserve enormous credit. Again, champions within these countries. So I'll stop to make the important point that we need to identify champions at a country level. We need to support them as best we can. I think ESMO clearly can do that in the countries in which you have the opportunity to work. And I think that the problem that has been so well outlined in the survey that Nathan's presented and in the initial videos that you saw from Jim, as well as the work of the Pain and Policy Studies Group, just tells us that we can do this. We just need to do it. So I'll stop at this point.